Thanks, Chris. Good afternoon, everybody. Let me get my slides started here. Okay, I'll be presenting, of course, on our project, but before doing that, I wanted to start with a little background on people with disabilities and their health care, why this is important, and a little review of accessibility and assistive technology. But first, a few notes on language. Some people might be uncomfortable talking to or about people with disabilities. There's one thing that can help. It's called the person first rule. So we say things like people who are blind, or a woman who is deaf, not blind people, or a deaf woman. It's a very easy habit to develop. In addition, I'll also be using the term personal health record, or PHR. There are actually strict definitions for EMR, EHR, and PHR, but we never follow them, so I'll be using PHR somewhat generically to describe any patient-facing system with the primary function of providing some access to some or all of their chart, as well as other features and functionality. In any health IT project, a good place to start is to try and find descriptive data on both your user and patient population. In this case, they're one and the same, people with disabilities. So I have just a tiny extract of data from the 2010 report from the U.S. Census Bureau. By their measures, 56.7 million, or 18.7% of Americans have some type of disability, 38 million, or about 12.5%, a severe disability. They break this out by age, showing that higher age groups do have a higher percentage of people with disabilities. In fact, over 19 million are over 65, but the majority are working age, and almost 5 million are children under the age of 15. They break out this data in many different ways, types of disabilities, severity within each. They even include economic data demonstrating that people of a working age with disabilities encounter economic disparities, higher rates of poverty and unemployment. Well, since the topic is healthcare and people with disabilities, there's another resource we can use to learn more about this and why it's so important. The Surgeon General's Call to Action to Improve the Health and Wellness of Persons with Disabilities is one of about 12 call to actions that they've published, each addressing an important issue in public health. The authors make it very clear that they want us to understand that people with disabilities can live a full life, but the key is health and wellness. However, they go on to cite numerous study after study demonstrating how people with disabilities face disparities with almost every aspect of health in the healthcare system. Access is defined in many ways and is a problem. They may have higher and or unique risk factors. All of this leads to poor outcomes and higher costs to, of course, the individual and society, some estimating in the hundreds of billions of dollars. Well, since that time, that report was published in 2005, there's been a lot of attention on healthcare technology, of course, especially patient-centered technology that seems to provide the promise that it will engage patients and improve care in every possible way. Well, if and when that promise is achieved, it has to address people with disabilities. However, beyond the gargantuan task of developing systems that address meaningful issues and measurable improvements in outcomes, we have to do one more thing. We have to make sure that people with disabilities can use this technology. And by that, we mean it has to be accessible. Excuse me. There are many definitions for accessibility. I think of it rather simply at two levels, design and code. At the design level, accessibility and usability are almost interchangeable. For example, consider someone with a mild visual impairment or maybe a mild reading disability. For them, good layout, good content, proper use of font, color, size, etc. can go towards making it both accessible and usable. However, people with a more severe disability require an extra layer, you might say, of technology, either software and or hardware, between them and whatever device or system they're interacting with. This is referred to as assistive technology. For assistive technology to work, of course, we still need good design. We also have to make sure our code follows certain methods and standards so that the assistive technology can either function with or interpret the information to the user. Well, there's a lot of resources, and we know how to make technology fully accessible. In addition, there's many regulations and laws. However, the track record needs a lot of improvement. I couldn't find anything more recent that was this comprehensive, but in 2007, the UN did an audit of 100 different websites in different consumer sectors. Only 2% met accessibility standards. Well, given that we have the knowledge and the resources, yet continually fail, the issue seems to be related to awareness and methods. Anyone who's worked in this field in accessibility has encountered a lot of people with different misconceptions about it. They may feel that their users or customers are not people with disabilities. I think the census data counters that, also marketing data, and as well lawsuits. So there are business incentives. Even so, they may view accessibility as something that's very expensive and complicated. They might feel it can impact usability or functionality. And that's just because, just like everything else, usability, requirements, perhaps even meaningful use, unless we address accessibility early in the development process, the cost of addressing it later goes by orders of magnitude. At the same time, our solutions are less than optimal. Still, other people might feel that accessibility can somehow impact innovation, and that's really unfortunate because there's a really long, rich history of innovation in assistive technology. So with that, I'm going to give a brief history of assistive technology used by different people, and also a little focus on innovation. Many forms, in innovation, one thing that seems well accepted is to look for early adopters. When it comes to new forms of interactive technology, people with disabilities are often so far ahead of us that they're the ultimate early adopter. If one person in technology could be given the title of genius, some people might pick Ray Kurzweil. He's the current director of engineering for Google, and he has a long history of invention and innovation. Way back in 1974, when he wasn't busy inventing new types of music synthesizers and samplers, he invented 3 other types of technology: the flatbed document scanner, omnifont character recognition, which would convert that image file to text so we could process it and search it, and also the first ever text-to-speech synthesizer, or the talking machine or computer. What's funny about this is he had no idea what to do with all this until he was on an airplane sitting next to a man who was blind, who told him how difficult it was for him to acquire reading materials in Braille. So he put it all together and invented the first reading machine that allowed people who are blind or visually impaired to scan any printed material, books, magazines, and have the machine speak it to them. And a little trivia, Stevie Wonder was his first customer. He also applied the same approach to help kids and adults with reading disabilities by adding a layer of display, even the original scanned image highlighted and as it was being spoken. Well, 10 years later, the personal computer really started to take off. And I think both Apple, especially, and Microsoft deserve credit for addressing accessibility early on and recognizing that it was important for their technology to be accessible. So you can try out today in your computers or even your mobile devices a whole variety of accessibility options and features directly in the operating system. However, they went beyond that and created a sort of framework, you might say, for developers, an application programming interface for accessibility that allows developers of both standard technology and assistive technology to create accessible solutions without having to solve complex problems. With the graphic user interface and the mouse, interaction is perhaps the most challenging for people who are blind. For decades, they've used software called a screen reader. It will interpret both input and machine output to synthesize speech. That, and along with a lot of keyboard commands that have to be memorized, that allows them to interact with a computer. However, despite its name, it's really not reading the screen, it's reading the code that generates that screen. So for the desktop, thanks to this foundational work by both Microsoft and Apple, this is largely solved, but it's a bigger problem on the web, where again, accessible coding standards need to be followed. So if the structure of the page and or the elements within it are not properly coded, that can render the site very confusing to completely incomprehensible. For people with physical disabilities, they may not be able to use a standard keyboard or mouse, and there's a whole array of alternative input devices. For the mouse, there's all types of trackball or joystick type devices. Some may not even be able to use any track or mouse type device, so we need to provide keyboard only access. As far as keyboards, there's so many different types: large key, colors, membrane keyboards, ergonomic keyboards for many different uses and situations, up to including people who type with a mouse stick. For some people, these alternate input devices might be enough. Others will require additional assistive technology software to improve speed, efficiency, and accuracy. There's a lot of software, and even the operating systems can help support this. I have a screenshot of a very old program that interacts both with standard as well as alternative input devices. It's called CoWriter. Came up with the Mac, perhaps I think in 1985, maybe 1987 at the latest. It does a lot of things, too much to describe here. One thing it does is pretty interesting, is it can display an on-screen keyboard, and that can reflect what's being typed on any keyboard, or it can be accessed on the screen via touch screen. People with disabilities have been using touch screens for decades. It'll also use word prediction to generate a list of words, thereby improving the user's efficiency. Well, I hope this sounds familiar. In software development as well as user interface design, there's something known as design patterns. These are solutions to some problem that can be reused. And this represents the design pattern that is fundamental to our typing on our mobile devices, yet has been used by people with disabilities for almost 30 years. Another way to think about this is when it comes to typing on a little piece of glass, we're all essentially disabled and require assistive technology. For people with even the most severe disabilities, there are further options, both software and hardware. This is referred to as the single switch and scanning. If you can move anything in your body, they can adapt or create some switch that you can use. It might be some large button you hit with your arm or hand, the side of your face. It could even be something you trigger by blinking or sipping or puffing on a tube. In fact, a lot of people control their wheelchairs that way. Switches can be applied to appliances, even toys, so kids can have fun and play just like every other kid. However, in interacting with a computer, it's more complicated, so we have to add scanning. In this case, scanning refers to the software or other software visually or even with audio highlighting selections on a screen. Could be keys on the on-screen keyboard, links on a website, or menus on some application. As it cycles through these options, when the desired option is highlighted, the user closes their switch by whatever method they can. They'll then move on to the next choice. This seems kind of cumbersome and difficult. It can be, however, it can be further augmented with a lot of intelligence and automation. It allows people with even the most severe disability to do anything with a computer. As an example, I thought I'd reference the most famous person with a disability in the world, if not the universe, Professor Stephen Hawking, the astrophysicist. The great thing about assistive technology is, first of all, there's no one-size-fits-all solution for anybody, and we can configure, again, hardware and software, modify it in different ways to meet anyone's needs. So I'm sure we're all familiar with his books and computerized speech. How does he actually use his computer? Well, he has a special computer mounted on his, it's actually an ordinary computer for the most part, mounted on his wheelchair. And then he uses a program similar to Co-Writer called Easy Keys. He's a Windows guy that has an on-screen keyboard, scanning, word prediction, and text-to-speech. However, where's his switch? Well, if you look on the lower right side of this picture, it's hard to see. There's a little bump on the lower right side of his eyeglass. That's actually a little infrared switch that he triggers by just sort of twitching or moving his cheek. So there you go. That's how Stephen Hawking uses his computer. Well, there's much more I could talk about, too much here, but I will provide some resources at the end of the talk, or you can always contact me or some other people in the project. In the meantime, though, because so much of our innovative technology has to do with how we interact with technology, it's really fun and interesting to think about what's happening in assistive technology right now that might lead to something we're all using sometime in the future. Okay, now about our project. Excuse me, the project is a collaboration of 3 different organizations. The project leader is the WGBH National Center for Accessible Media. Beyond all their wonderful public television and radio shows, Frontline, Nova, Car Talk, WGBH has been a pioneer in inventing assistive media technology. The first ever caption TV show ever was Julia Child in 1972 on WGBH. They went on to develop more sophisticated forms of closed captioning as well as descriptive video for people who are blind. Like your computer, you can go home and try out these features or options on your cable box. NCAM consults with a lot of large media and technology companies. They also are engaged with policymakers, and they recognized early on that we needed to bring attention, with all the attention on health IT, to accessibility as well as usability and everything else. The second partner is right here in Philadelphia, Inglis House. They've been managing the care of people with severe physical disabilities for over 150 years. They have a 300-unit residential facility, and they also manage the care of about 1,000 people who live in the community. They're very committed to finding health technology that allows their residents and consumers to be fully engaged in their care. And they contributed to the project beyond just their expertise and as a source of subjects, but also via their Assistive Technology Computing Center, where they have maybe 20, 25 computer stations with every type of assistive technology you can think of, and experts who help their residents and consumers use this technology to do anything it is they want to do. They set up some assistive technology usability testing stations we used in the project. Then, of course, there's CHOP and DBHI, myself and my boss, Dr. Robert Grunmeyer. We have experience developing decision support for not just clinicians, but patients and families. I also want to acknowledge our developer, contractor, Jason Withrow from Usable Development. He has a master's in HCI, a web developer, and some accessibility expertise. The grant was awarded by the Department of Education National Institute on Disability and Rehabilitation Research. They call this a field-initiated development grant. Essentially, that's a demonstration project demonstrating some process or methods of benefit to people with the most severe disabilities. So what are we demonstrating? At the highest level, we want to simply contribute awareness and also resources and methods to anyone in health IT, developers, vendors, entrepreneurs, and policymakers. The vehicle for our demonstration is to design a PHR using a comprehensive user-centered methodology and to share all our results. Of course, we can't build a real PHR, so the final product was a set of interactive prototypes suitable for usability testing by any person with any disability. As I mentioned before, so often software is developed without thinking about people's disabilities, and that leads to problems later on. We figured, why not take the exact opposite approach and design our system with and for nothing but people with all types of disabilities. Over 200 participated in different ways. And as a bonus, beyond demonstrating usable and accessible PHR designs, we feel this can also lead, because of all the disparities and issues and complex care requirements by people with disabilities, this can lead to a more functional and even innovative PHR that will not only address their needs, but everybody. That's nothing new. Again, back to the 70s, that amazing decade. The concept of universal design. If we broaden our design perspective to include people with disabilities, the result are designs that not only address people with disabilities, but are more elegant or versatile for everyone. This was initially applied to elements in architecture. The curb cut is probably the most cited example. I may have given examples of electronic curb cuts earlier. Somewhat related to this is, or highly related to this, I should say, is another idea or philosophy, designing for the extreme user. If we think of our user population as a normal curve, we might be tempted to think that we should be designing for people in the center of that curve, the average or typical user, when others have demonstrated a better approach and a more innovative approach is to design for people on the tail end of that curve, the extreme user. In regarding disabilities or accessibility, this has been demonstrated with a lot of commercial and innovative success in, believe it or not, kitchen devices, ergonomic kitchen devices. The most famous, perhaps, design firm, an innovative design firm in the world, IDEO, applies this approach, though to all types of different and extreme users. And you think about it, a lot of our work in DBHI, and perhaps even over at CHOP, is the same approach by developing solutions for the most complex patients and their care providers. We not only develop systems that address their care needs, but that can be applied to everybody. Okay, on to methods and results. The first thing we did is we did not code anything. Instead, we spent a lot of time via multiple methods studying our user population. So let me go through that. The first thing we did was a set of semi-structured interviews with 16 people with different disabilities. And the interviews were based on 3 open-ended questions. First question was to have them describe to us their goals, what it meant to be living independently. Their responses echoed a lot of what we read in the Surgeon General's report, what you can read in the Surgeon General's report. The next question was to tell us the connection between health and their independence. And here they clearly echoed the Surgeon General's report. Health was the most critical, important factor to not only achieving but maintaining independence. Any setback or delay in care can lead to jeopardizing all the work they put towards living independently. The third question was to have them describe to us ideas, scenarios from their own care on how they could use information, communication, or technology to better manage their care. And this, for me, was really the most amazing part of the entire project. Because of their, again, being extreme users, we might say, of the healthcare system and all the different issues and barriers, they provided not only super detailed, but very sophisticated scenarios and ideas, many representing some of the most important issues in health informatics. So we compiled their feedback into a set of 22 high-level use cases. However, each use case can be sort of expanded if you apply what I'm calling, I just made this up, requirements attributes that are shared across all the different scenarios and came from our subjects. For example, information access. They want access to the complete record, and they want that access to be shared with everybody in their care team in every possible situation and scenario, and also on every device. In effect, they're describing interoperability, but with a patient-centered focus and perhaps more detail than we're used to thinking about. Control. They don't want to just access their chart, they want to be part of updating it and even correcting it. We do a pretty poor job of collecting and keeping up to date on patient histories. They want to help manage this. Clinicians really don't have time. Communication, far more sophisticated forms of communication, not only between them and their providers, but between their providers. They're talking about care coordination and other people on their care team. Education, there's plenty of stuff on the web. However, a lot of it isn't accessible, nor can it always be trusted. They want trusted and accessible content integrated in many ways directly with their PHR, and they suggested ideas similar to the info button or context-based education or even information prescriptions. Insurance, sometimes the most difficult part of part of healthcare is all the red tape. If we can't streamline these processes, they want these systems to help manage all this, pre-certifications, referrals, approvals, et cetera. In addition, because of their often serious limitations on income or benefits, they want to be fully engaged and have tools to help them achieve the best possible care at the lowest cost. They also want help in managing equipment and supplies and other things related to their care. So again, if you sort of inherit these attributes to any one of our 22 use cases, it provides requirements that far exceed the capabilities of any single PHR available today. I've looked at maybe 40, so I can say that with some confidence. So for example, managing medications, access to both past and present medications, then the ability to correct or add or update those medications, including the addition of supplements or over-the-counter medicines they might be taking. More sophisticated communication around their medications, tracking progress, lab tests that might be required, monitoring side effects. Of course, accessible education materials for patients, how they take this drug, what they might be looking for or to expect. Also, what does this drug cost? Are there other lower cost alternatives I can explore with my provider? So the next thing we wanted to do was validate and prioritize the 22 use cases with a larger sample of people with disabilities. So we put together a web survey, and the main purpose of the survey was to have our subjects rate the 22 use cases in two ways. First, how important is this to you in your care? Second, what is your current level of satisfaction in managing this particular issue? We also included a lot of information on their disability, use of technology, all that's available on our website. Also, we had to make the survey accessible, not as easy as it sounds. There's one vendor really who leads in this, that's Survey Gizmo. I hate to say it, but a commonly available research tool is not accessible for surveys. 150 people completed the survey. We got a lot of compliments on how accessible it was. In blue are the ratings of importance, the percentage of participants who rated the use case as important, and it's sorted in that order. The range is from 98 to 74%. By contrast, in orange are their ratings and their current level of satisfaction. Only 3 topics scored just above 50% satisfied. The rest were much lower. There's a few ways you might interpret this. One is that it does reflect some of the information from the Surgeon General report. In terms of our requirements, now we pretty much knew that we could address anything that was important and had room for improvement. The next thing we wanted to do was assess the current state of PHRs for accessibility, usability, and functionality. We were a little naive at the beginning of the project. We thought vendors might supply us with a test system so we could do very detailed baseline usability testing. Those that responded politely declined, and I think we can understand that. However, we had to do something, so we even looked at some systems from our own care or those available online. So we looked at 3 systems: a hospital patient portal connected to a hospital EMR, a patient portal connected to an ambulatory EMR, and a consumer or web-based PHR. So how did they do? Well, accessibility was reviewed by the WGB experts. They do this all the time for very large companies using both automated tools and manual review. The hospital PHR only met 6 of the 12 accessibility standard categories. The ambulatory and consumer PHR met only 2. In terms of usability, without our objective usability testing methods, we applied pretty well-established subjective methods, heuristics, and cognitive walkthrough. In this case, the hospital PHR had the lowest level of usability, though the other 2 had problems as well. Problems really seemed to center on navigation schemes that ignored or did not apply the most basic techniques in information architecture. So navigation was often very confusing, inconsistent, unbalanced, and redundant. And if and when these systems had even more functionality, that navigation system would even produce even more problems. There was other issues as well. Functionality, we compiled a list of 43 or so different features or functions a PHR could provide, and that many do, and then assessed each of the systems. The hospital PHR was the least functional. Only 12 out of the 43 functions were available. The ambulatory PHR was pretty sophisticated, some functionality even approaching that described by our subjects. The consumer PHR was also highly functional, but because it is in no practical way interoperable with a clinician system, it has some limitations. So overall, each system did something somewhat well, or particularly well, and from looking at all these screens and going through every single task these systems provided for weeks, it really became clear that if you could somehow put them together, you would have a very nice PHR, as long as addressing accessibility a little better. And from that, really, the conclusion seems obvious, and almost an epiphany in some ways, but the real issue here is not our technology capabilities, but simply a very systematic requirements process followed by user-centered and accessibility methods in our development process. So with a better understanding of our users in the current environment, it was now time to go on to the design phase. And we applied an approach very similar to what Ray Rosen spoke about here about 2 months ago, very iterative design approach with lots of easy and disposable mock-ups until we met our objectives. One issue here is that there are some common prototyping tools or mock-up tools used for this type of work, so you can create actual simulations of interactive systems on the web. However, they produce code that is completely inaccessible. And I think this is really unfortunate, since a lot of attention on accessibility is now coming from people who work in the user experience or design field, and the very tools they're using can't support working with people with disabilities. I did write 2 of the companies, and I never heard back, and perhaps I should write them again. I was polite. Okay, now on to our designs. This is the homepage of our PHR. It might seem kind of simple, but there's actually a lot of thought and a lot of problems addressed here. First, if you look at many different PHRs or even PHR design contests, most of them have a homepage that looks kind of like a corporate dashboard. And many of our early designs, our mock-ups, applied that approach, and it was immediately rejected by our subjects. They said things like, this isn't for me, this is for my doctor, I know who I am, or this might be important in some way, but it's certainly not the first thing I need. Instead, since we're providing access to the complete personal health, the complete medical record along with these other tools and resources, why not use all this space instead for simple, clear navigation? We added to that sort of a sitemap strategy organized by meaningful categories, visual and accessible indicators, because charts are very dynamic, indicating anything or any area of the chart that had something new or had been changed, and also anything that required attention. This same approach, unlike the other navigators we saw and have seen, also adapts very well to what's called responsive design, where your same system or site will automatically configure itself for display on even the smallest mobile phone. We learned from an expert who spoke here a few months ago that making your site responsive, the same coding methods could also go a long way toward making your site accessible. Good code is often accessible code. Patient education. Again, our subjects wanted all types of accessible content directly integrated with their PHR. To do that, we built on some previous work from WGBH, where they developed a K-12 education portal for kids and teachers. Along with organizing all their content by subject and grade level, they applied something called media tagging or meta tagging. So all the content was tagged by its type of media, allowing a person with disabilities or others to set media preferences. So, for example, videos with captions, text only, audio, etc. That way, whenever they might be assigned something or do any searching or filtering, they're returned only content that they can access. We feel this strategy could be applied to many existing systems. Some are capable right now of being connected to not just one, but multiple education resources, because more than likely no single source of content will have accessible content for everybody. So that, along with, again, this meta-tagging strategy, could not only help people with disabilities be either prescribed or retrieve accessible content, it could help everybody by addressing maybe perhaps preferences for age, literacy, language, or even their preferred learning style. As an example, I have 3 different forms of education here on the same topic, asthma. One is from Medline Plus, the National Library of Medicine. That's at the top. Below that is kidshealth.org. Not only does that have content for kids and parents, it has a very much a Kurzweil feature where it will speak and highlight the text as it's being spoken by the computer. That's available, I think, by a company called ReadSpeak. You can find that to any website. And below that, a very unique resource we found called deafhealth.org that has videos of people signing, all types of different content on diagnoses and medications and other issues. Care plans. Many people with severe physical disabilities rely on a care plan, a list of daily tasks they need to manage for their health, given their independence. This is maybe 1/3 of about an 8-page care plan one of our subjects shared with us. It's a very clinical document, and/or it seems to be written primarily for those who approve the payment for this care plan. What it does not do is provide a nice, clear schedule of tasks and information to support those tasks. So we created that in the PHR. This might again seem rather simple, but I challenge you to find any PHR system that addresses care plans, even beyond attaching a PDF. Our care plan, beyond a simple list of tasks or scheduled tasks, has information supporting each task with something we do almost every day, personalized content linking to it just like we do in Facebook or anything. So, for example, the first task here of the day is to transfer the patient from the bed to the wheelchair using a Hoyer lift. So we found a WikiHow page and also a YouTube video demonstrating how to use a Hoyer lift. The person might have a new home healthcare aide or a family member or someone who needs this information. Later in the day, they might have to do some exercises prescribed by their physical therapist to maybe maintain their range of motion. Instead of these little index cards that PTs seem to copy and hand out or photocopy, why not make your own video, exercise video? That's exactly what I did. I took out my phone and videoed one of the English physical therapists demonstrating some exercises and attached it to my chart. This could also be content attached by the provider. It could be anything, really. Later in the day, we have a connection to either forms or even an app to record and track fluid intake and output. Well, given our universal design idea, lots of people have care plans, not just people with severe disabilities, people with all types of chronic illnesses, even someone who might be recovering from surgery or an injury. They have instructions they want to follow. So we applied the same design pattern to an asthma care plan for a child with asthma, and it can be printed on a single page, but online it has all types of, again, content that may be prescribed by CHOP videos on what's asthma for both parents and kids, demonstration of how to use an inhaler, things like that. Equipment and supplies are very important to many people, especially to people with physical disabilities, from their grab bar in their shower to their $30,000 power wheelchair. Tracking and keeping information on all this equipment, getting it repaired or replaced is very cumbersome. Why not just have a simple database in the PHR. In addition, it was very difficult to find any systems that addressed equipment beyond surgical implants. This also provides a lot of assistance in transmitting information. Sometimes the most difficult part of getting this equipment, for example, your very sophisticated wheelchair repaired, the first thing you have to do is get a prescription and a lot of red tape and things like that. So there's more designs, more scenarios on our website, but we went on then to our summative usability testing, and we tested 16 people with different disabilities, and I show here a little table of describing their disabilities. Some had multiple disabilities, as well as the assistive technology, and there's quite a variety here used by different subjects. Of course, some used no assistive technology. Sometimes I think there's a little confusion about usability testing. Usability testing is really based on scenario-based, having subjects attempt to perform tasks independently with the system, and while doing so, we collect both objective and subjective data. Objective metrics include task completion and usability errors. Those are very standard. We added accessibility errors as a metric, and it was very easy to determine which was which. Subjective metrics are derived from Likert scale survey questions after each scenario and after the test, rating the system on various attributes. So we can talk about our results. Task completion. Ideally, you want to achieve 100%. We did not. However, there's a bit behind that. First, 3 of our subjects of the 16 represented, but all except one of those task failures. Each had a different disability. 2 had a unique or severe disability. 1 had a cognitive disability from a stroke. The other had a severe physical disability plus a severe speech impairment, and we were told that she tired very easily. For both subjects, and they completed only one scenario between the 2, it seemed to be a combination of our failure to communicate with them or to have them understand the scenarios or even develop scenarios that they could relate to. And as a result, they needed a lot of prompting. Whenever someone needs a prompt in a usability test, you record that as a usability error and also the failure to complete the task without completion. The third subject who had issues was one of 4 people who are blind who used a screen reader. She was the first person we tested. Even though we tested our system with many different screen readers and browsers, don't get me started on the browsers, she had a different combination, an older version than we had tested with, and there was a lot of problems in her screen reader really failing to integrate with some of the latest accessibility standards that our developers applied. As a result, the screen reader was repeating things and very verbose, leading to a comment you'll probably never hear in this type of work: it's too accessible. So anyways, we decided to address her issues in the mid-test, and later the other screen reader users, 2 had no errors whatsoever, 1 only had a few minor errors. Another way of thinking about this is when you apply a very detailed user-centered method process, especially with lots of formative or iterative design, that when you test your system, of course you're going to have some errors. And however, because of applying this approach, those errors almost always suggest very clear and low-cost fixes. The exact opposite occurs when you test a system that was designed without any formative or usability methods. In addition, we also collect subjective results to understand sort of the whole picture. Our subjective results, we're very high here in terms of satisfaction on usability, accessibility, and functionality. I always throw in a little trick question: does the system need any improvements? Of course, along with minor issues, our subjects, like all other subjects, had endless ideas about how the system could be expanded in terms of functionality. It's not very scientific of me, but sometimes I think just beyond all this data we collect, that user comments are sometimes the most interesting or revealing. So I have a few here. This was from that woman who had the most trouble with her screen reader in her system. Maybe this will help you understand how bad it is for me. There are accessibility problems with this, but it is by far the most accessible health application I've ever tried. Other subjects who didn't quite understand our project may have been a little overwhelmed with usability testing. They felt that, or thought maybe that the system was real or would be available soon. And this led to something that was it was very depressing. They would say, this would be great, this would really help me. When will this be out? When can I sign up? So I had to explain to them that our goal here was to collect not only data, but information, experiences, and ideas from them and 200 other people in the project, and share that information with people who develop or design these systems, as well as those who write policies around it, so that sooner rather than later they can have a system like this. So given that, we're now in our outreach or dissemination phase. We have our website. There's a link here, healthitaccess.wgbh.org. Just yesterday, Madeline Rothberg, the project manager from WGBH, presented to the Federal Intra-Agency Committee on Disability Research. That went very well, of course. We also have a few conferences coming up, and hopefully more. One of the education aims here today is how do we include people with disabilities and usability methods. I've worked with hundreds of people both with and without disabilities, and I think the good news is it's really not that hard. Only minor modifications in our methods and approach are required. However, there may be 3 topics that require special attention. First, recruitment. How do we find people with disabilities? Well, we were spoiled. We had Inglis as a partner. We also needed to recruit other people who are blind or deaf, so we found another independent living organization in Philadelphia. Liberty Resources, that not only connected us with more subjects, but American Sign Language interpreters. However, you might pursue libraries, universities, maybe veterans organizations, or even large employers. Online, for our survey, we used online communities that WGBH is quite familiar with. However, you want to be careful not to over-survey these people. Next, transportation. It's often very difficult for people with different disabilities to find or have reliable transportation. In fact, I had, maybe 8 or 9 appointments canceled because of transportation failures. It's much easier to just go to them. In fact, I went to many people's place of work, even their homes in a few cases. In addition, some may have very sophisticated assistive technology setups. If you try to replicate this in your usability lab, I can guarantee you almost that you will fail. Just go to them instead. Communication. Some minor modifications. First, with American Sign Language, there's a lot of protocol with that. To be careful to look at the person, not the interpreter. It's considered very rude, so you can help arrange the room to avoid that. People with severe speech impairments, it's often helpful to have someone on their care team or family who can help with communication. And in usability testing, we use something called the thinking aloud protocol. This isn't really a problem. It's just kind of interesting with so many people talking to computers, or computers talking back to them, or people signing. You have to modify that a little bit. Well, there's other resources much more comprehensive than what I'm presenting here, and there's 3 books I'd like to recommend. First is Just Ask by Sean Lawton Henry. She provides ideas and advice on including people with disabilities in every usability method you can think of. Next, there is A Web for Everyone by Whitney Quesenberry and Sarah Horton. They demonstrate the application of user experience methods in web designs to both include and address people with disabilities. Also, Digital Outcast by Kel Smith. Again, more methods, but he also includes endless examples of how assistive technology has led to innovation. Okay, my last slide here, I promised some CHOP and other local resources. If maybe you're interested in accessibility or assistive technology for your patients, families, or friends. So first, within CHOP, We have a great resource for assistive technology for CHOP patients. That's the Little Rock Foundation's room. That's run by Sandra Huey. It's on the first floor of the Seashore House. She works with not only kids, but their parents to identify, acquire, and learn how to use assistive technology so kids can do anything kids want to do. We also have some really unique experts who study and address the often difficult transition to adulthood for children with disabilities and or chronic illness. I'm most familiar with Simi Trachtenberg, who was recently recognized by our executive leadership for her work in this area, and I discovered that Chris Bonafide and Simi had written a paper together some time ago, or more recently, on this very subject. Another resource, a CHOP career path, hiring young adults, many former CHOP patients, and that's run by Jamie Diani, along with Allison Sims, and maybe other people who work there. I'm sorry if I don't know them, also with Simi. And so they have people working all over CHOP. CHOP and other hospitals are great places to work, all kinds of jobs, room for advancement, etc. Finally, to make CHOP more accessible to employees is the All Abilities Resource Group. This is a volunteer committee open to anyone at CHOP, meet once a month. It's run by Frank Lamacchia. And if you're interested, you can join our meetings whether you're disabled or not. Outside of CHOP, in Philadelphia, we have some great resources. The Temple Institute on Disabilities is a really fantastic program. They provide all types of research and services. They have something that's very unique and much in line with the long tradition of free libraries in Philadelphia, the Pennsylvania Initiative on Assistive Technology, or PIAT, a lending library of very expensive assistive technology so people can decide and figure out what assistive technology they actually need before making the purchase. We also have a Philly Accessibility Meetup, 800 feet high in the Comcast building every month. It's open, mainly attended by developers and designers interested in making their technology accessible, but it's open to everyone. And also, finally, I see everyone looking at this all the time. I want to acknowledge our captioning service. Talk about extreme users. If they could keep up with my rambling style, then they could caption anybody. That's archivereporting.com. Very reasonably priced, and at the end of the talk, you get a transcript. That may not be good news in this case. Anyways, that's the end of my talk, and maybe if you have any questions or discussions, we can open things up.